Good afternoon, everybody. We're going to take the discussion to pediatrics now. My name is Dinima Wela, and for this session, Professor Mbati, even though you think I'm not a pediatrician, I'm wearing my pediatrician hat. We have on the panel 3 experts in the field within the institution. And I'm going to introduce them briefly. As Dr. Lusani said, I'm going to start with Dr. Aleta Mutene. Raise your hand so that they see you. Aleta Mutene is a pediatrician too, like me. She's a graduate of UKZN, but we are pleased to have her in the department. She's actually a trained, registered pediatric pulmonologist, the lung people. She prides herself in being a mother of 2 children who have asthma, so she did this to deal with her family issues. We also have with us Nomasiko Zulu. On the other side is a dietitian here with us, also a graduate of UKZN, who is currently working at Dr. George Mukari. And for those who are having issues with their nutrition, she likes to help people make sustainable lifestyle changes, and that's good English for people who want to lose weight. Then we have Dr. Kumrin Malepamala. I hope I got it right today, Kumrin. She's a senior registrar with us here at Sefako Makgato Health Sciences University within the NHLS. He has just obtained his fellowship with the Colleges of Medicines of South Africa. So he's a chemical pathologist. Yeah. So the 3 panelists are actually going to take us through cystic fibrosis. For those who want to know, cystic fibrosis is a rare disease. It's inherited. It's one of the genetic disorders. It affects all the system. It's a multi-system disease, although most of us know about the lung manifestations and how it affects the pancreas. The basic problem with cystic fibrosis is that all the organs in the body become clogged up with secretions, which may eventually lead to failure, particularly of the lungs. In the South African context, we do have a cystic fibrosis registry where all these patients are registered, but we can tell you that the numbers on the registry, which is anything between 700 and 1,000 patients, are not a true reflection of the situation in the country, because we know that we are missing a lot of them, particularly in the hard-to-reach areas, which speaks to access. But because the manifestations are in the lungs, it can look like HIV, it can look like TB, it can look like asthma. So these children are generally misdiagnosed or diagnosed very late, and therefore, sadly, most of these patients, as I said, will die very young. So we really have a challenge of access to diagnosis and treatment, and that will come out in the discussion. But for us, what is important is to begin to advocate for newborn screening in this country, because where there is newborn screening in areas like the UK, 75% of these cases will actually be picked up at birth and will be therefore managed better. Colleagues, ladies and gentlemen, it gives me great pleasure to invite Dr. Aleta Mutene to the stage to share with us one of the cases that was diagnosed within our institution here at Dr. George Mukari. Dr. Aleta Mutene.
This one.
Good afternoon, everyone. Our esteemed guests, SMU community, I welcome you to our afternoon session where I'm going to take you through a journey of a child with cystic fibrosis. Like Professor Mawela said, it is one of the patients that we managed in our institution and one of those that were lucky to be diagnosed. So this is a journey of Miss LM. I gave her the surname of Salty, and simply because cystic fibrosis has to do with a problem of control of salt. So if salt is not controlled, then these patients will end up with multi-system diseases. Let's follow the journey of Miss LM. So this is a patient that presented to us at the age of 6 months. She came from one of the district hospitals where she was admitted at the age of 3 months. She presented to the district hospital with a chronic cough and difficulty in breathing. At this point, the district hospital doctors thought this child has community-acquired pneumonia. This child spent 2 months in hospital where was being treated for persistent community-acquired pneumonia. Of note is this child was on oxygen, was failing to come off oxygen, and was also not growing well, so was having failure to thrive. After 2 months of hospitalization, was discussed with Dr. George Mokari Hospital and transferred to our unit at the age of 5 months. At this point, we were wondering what exactly is happening with this child. Is this child having structural anomalies? Maybe it's aspirating, or is having a genetic condition? The background history is that this child was born a term, so it was not a premature baby who's having a chronic lung condition. There was also an important history, that is that the patient had a delay in passing meconium. So meconium is that first stool that the babies pass after delivery. So it is an alarming a sign if a child has a delay in passing meconium. And that is why we always do not send them home before they pass the first stool. The other important thing is that the maternal grandparents are of Caucasian origin. So in our institution, this child arrived on oxygen, was having these thick mucus secretions around the mouth. He was not looking any abnormal, not dysmorphic, and she had normal pulses to indicate that the heart was probably normal. She was looking all wasted, but had these big eyes looking at us, crying for help. She also had normal stool. So usually these patients will have a foul, greasy stool because of affectation of the pancreas. She also had digital clubbing, so the fingers were all big, meaning that this child has been having a chronic problem, lung problem. She was not cynosed. She had a chest deformity already, and she had a signs of pneumonia. The heart clinically was normal, and the neurology of this child was also normal. So at this point, we were thinking, is this child having aspiration pneumonia? Is this child having tuberculosis? Is this child having a congenital heart disease with all the fluid flooding into the lungs? Or are we dealing with some immunodeficiency where the kids do not have a strong immune system to fight organisms? Or are we dealing with a genetic disorder, cystic fibrosis? So we went on to investigate this child further. The TB investigations came back negative. The heart investigations were normal. The brain investigations were normal. And we went on to investigate for primary immunodeficiency, which the results were normal. And we went on to investigate for cystic fibrosis. Like, if you can see that, like in an African country, we went for common things first before we investigated cystic fibrosis and primary immunodeficiency. Bearing in mind that these children can also have a dual disease. So it means that you can have cystic fibrosis and still have other conditions. So we didn't want to miss other conditions. So the HIV came back negative. Other laboratory investigation showed that there was infective process going on. We took the sputum for investigation, as cystic fibrosis affects mainly the lungs as one of the organs, and we grew numerous organisms. But of importance is the Pseudomonas aeruginosa, which is seen commonly in patients with cystic fibrosis. There was also Staphylococcus aureus. We did the stool for fecal elastase, which tells us about the pancreatic levels in the body. So the pancreatic level in the stool was was low. So we went on to do a gene test, which is we test for the abnormality in the cystic fibrosis transmembrane regulator gene. So the test came back and it was positive. We could not do other tests as we do not have those facilities in our institution, namely the sweat chloride test and if this baby was born in George Mukhari, we wouldn't have been able to do a newborn screening test either. The chest x-ray showed that there was an element of pneumonia, but another important thing is that there was already early damage of irreversible lung disease. We call it bronchiectasis. But fortunately, the babies, as they grow, new lung also develop. So if we manage to catch them early, as they grow with good nutrition, we are able to salvage their lungs. So like I mentioned, the brain was normal. So what did we do for this child? Because of prolonged hospital stay, this child was in and out of ICU, requiring respiratory support. She was on a ventilator for a duration of a month. And after that, she required to be on other non-invasive supportive, meaning oxygen, and will go on to room air. But because we were not treating the underlying condition, we'll go back onto a ventilator in ICU. We required to do pharmacological therapy, meaning antibiotics, and these patients require both intravenous and inhaled antibiotics. And the treatment for these children can go on for a longer duration, for a minimum of 2 weeks and going on for months. We had to give this child an enzyme replacement, a pancreatic enzyme, which comes in pellets. And it was difficult to administer this treatment because this is a tiny baby who is feeding via a nasogastric tube. And the lumen of the tube, the radius is very small. So these pellets sometimes will just clog this nasogastric tube, and that will lead to a further deterioration of the child, because now if you don't get this enzyme, it means that you cannot digest the food. If the food is not digested, it will just pass out, or the child will not absorb the necessary nutrients. We had to nebulize these children with a medicine that breaks down the thick mucus that clogs the lungs and the reproductive organs and so on. So it's a multidisciplinary system management. So we invited the physiotherapist on board that helped us with clearing the lungs, the dietitian with for nutritional support. And because this child failed to grow despite other measures for nutritional support, we had to invite the pediatric surgeons to insert a feeding tube on the abdomen. So that feeding tube has a bigger lumen. So it was easy now to administer the medication. And with that, the patient improved, gained weight, and that actually improved the lung function of this patient. We invited the audiologist and the speech, because this child has been on polypharmacy, a lot of medications, and some of them affects the hearing. So we had to invite the audiologist to make sure the child can still hear. The speech therapist, this child has been on nasogastric tube feeding for a prolonged time, so needed to be taught how to suck again. So we registered this child on the Cystic Foundation, Cystic Fibrosis Registry. We also enrolled this child for care dependency grant, and the psychologist and the social worker for the family, because these are young mothers who were looking forward to having the normal child, and all of a sudden they are faced with a lifelong disease. So they needed psychological support, also to assess the family circumstances, because these children sometimes have to go home on oxygen. So you can imagine the stress that this family was facing, having a child that has to go home on oxygen. Not that only, but having a child who has to feed via a tube that is on the abdomen, meaning that the food has to be blended, because you cannot give pap through that tube. So that's how we managed our patient. But I just want to take you through the timelines. This baby was born in December, and then admitted to a district hospital in March, transferred to George Mokari in June. We collected the sample for cystic fibrosis gene mutation test in July, and we only got the final results in October. So by the time this child celebrated her first birthday, she was still in hospital. This child stayed for more than a year in hospital. But the beautiful thing about it is that we had a diagnosis, and this child, at least the quality of life is better. So what are the challenges that we faced in our institution regarding this child? Prolonged ICU stay, prolonged hospitalization. With that comes hospital-acquired infections. We had, as you've seen in the timelines, the delay in getting the results. Of note is that this test gets sent to another center. The newborn screening. This child, when he was born, of course, if history was taken, could have benefited from newborn screening test. We do not have a sweat test in our institution, and it took time for genetic results to be obtained. This child was on polypharmacy. Sometimes he will have nausea and will have vomiting the feeds, and that will take us a step backwards. And the other thing is that, is there treatment for these children? Is there treatment for these patients? Because what we are currently doing is just doing supportive management. I'm sure every parent would like to have a child who would grow well and succeed in either their career. But if you get told as a parent that there is no treatment for your child, it must be very devastating. So the question is, what are we doing about it? So out of this case, the good thing is that the diagnosis was made. But is it for the clinicians? Is it for the parents? The bad thing is that the diagnosis was made late. As we heard from our previous speaker, that her child was only diagnosed very late. The ugly thing is that this is a lifelong condition. So as Prof has mentioned, this disease is multi-system. It can affect the pancreas, meaning that you do not have enzymes to digest the food, so you can't grow. It affects the lungs, and that is why most of these patients succumb to the disease secondary to infections or respiratory failure. It affects the reproductive organs, so even if they grow, the chances of them having children are very slim. And it also affects the GI system, so they can also have intestinal obstruction, amongst other things. I don't know if you guys are aware of Nompilo Dlamini. Is a lady who succumbed to cystic fibrosis sometime last year. She had chronic lung disease. She was emaciated. She was on home oxygen. She also had organism that if it's cultured in the sputum, then you are not eligible for lung transplant. She went as far as going overseas, and she was told she's not a candidate. The question is, had she been diagnosed earlier, would that have made any difference? And thank you.
Good afternoon, everyone. I am Dr. Malapamala. I'm from the Division of Chemical Pathology here at DGM and SMU. In her introduction, Prof highlighted the South African Cystic Fibrosis Registry, and it's part of the association. I thought it appropriate to highlight it again because it was recently launched in 2018, and it is active. It's providing guidance and support to patients, families, and clinicians, and it is important to understand its existence and the role that this organization has to play in the management of this condition. In chemical pathology, we focus on the mutation analysis and then the diagnostic workup of these patients, and these are aspects that I've highlighted in this presentation. So this is the, this is the causative mutation in this protein, the CFTR protein. This protein is present in all tissues, but with a high predominance in the GIT and the respiratory systems. It's got these two transmembrane domains, TMD1 and TMD2, that sort of form a channel through which chloride is able to move through across the apical surfaces. Now, in terms of the mutations, there are 6 classes of mutations, and it is important to understand that between classes 1 and classes 6, the mutation severity gets less and less. So the disease severity tends to get less and less. The class 1 mutation is a very important mutation within... Thanks. The class 1 mutation is a very important mutation within the South African context because it results not only in premature termination of the messenger RNA that is required to translate the protein, but it is found with a high predominance. The mutation that is found with a high predominance within the black population of South Africa, the 3120 mutation, is a class 1 mutation. And this means that these patients tend to present very severe and very early on in life. As with the patient that was highlighted in the case, the child was born in December and presented in March with suspected community-acquired pneumonia and maintained a position within the ICU for almost the entire year. The class 2 mutation is the delta 508 mutation that is commonly associated with patients of European descent, our white patients in our population. So in terms of cystic fibrosis on the African continent, it is sort of a checkered past because traditionally this condition has been associated or assumed to only affect white patients of European descent. In the early 2000s, the World Health Organization released a report, and in that report, it was noted that mutation detection rates were significantly higher within the European nations and other first world nations, and this sort of led to the perception that cystic fibrosis is not present within the African population. At the time, only 2 African nations even had data that was publishable, Algeria and South Africa, both of whom recorded much lower detection rates. Now, why is cystic fibrosis so difficult to diagnose within our population? Well, firstly, the perception hasn't been completely dispelled amongst clinicians or caregivers. The awareness of the condition that it affects multiple ethnic groups has not been completely overcome or highlighted. We also have a higher incidence of other conditions, HIV, protein energy malnutrition, and these are at the forefront of most clinicians' mindsets or minds when they are examining or evaluating a patient. There's also a lack of the classic symptomatology. So not all patients will present with the classic symptomatology associated with cystic fibrosis. And then we also have sweat test limitations, both in terms of logistics and in terms of interpretation. Finally, the causative mutations in African patients has not been completely elucidated, right? And you cannot rely on commercial testing kits. Why is that the case? Well, there are over 2,000 mutations that have been identified in this protein or in this gene. And commercial testing kits range between 10 to 50 mutation kits. So they're only able to detect either the 10 or the 50 most common mutations that are present. As I mentioned earlier, the delta 508 variants are commonly found in our white and our colored patients, and the 320 mutation is found in our African or Black African and colored patients. Based on the carrier frequency rate of these mutations, it's estimated that 1,000 births of these patients are occurring every year, most of which are going undiagnosed. So in terms of sweat chloride, there are 2 applications for sweat chloride as it pertains to cystic fibrosis. The first is concentration. We use that to confirm the diagnosis. The second is conductivity. Conductivity is a well-established modality as a screening tool. And that is why, in part, they have higher detection rates within the European or the first world nations, because they have these newborn screening programs where they are performing conductivity and are able to pick these patients up much earlier, and that obviously improves the prognosis. So the instrumentation that we run sweat chloride on should have a lower limit of quantification of 10 millimoles per liter. And yes, during our day-to-day functions on healthy patients or even sick patients in the hospital, we have instruments that are able to run chloride. However, they are not able to run chloride on sweat. Running sweat chloride requires specialized instrumentation that we don't have access to here at DGM. The process is fairly simple. It's a two-step procedure where we induce localized sweating. We take a small current. It's not that painful, apparently. We take a small current and we introduce a drug that is able to stimulate localized sweating. And then this sweat is collected either on gauze or in tubing, such as a macroduct. And then we partition the reference intervals to enhance the specificity of our sensitivity and specificity of our cutoffs. So in terms of false positives, why would a patient have a falsely elevated sweat chloride? Well, if there's evaporation or contamination. And this speaks to the need for specialized, not only specialized instrumentation, but specialized personnel that are trained to properly evaluate and perform this investigation on patients. The recommendation is also that the sweat chloride needs to be analyzed on the same day. Now that creates logistical challenges because the sweat chloride that is collected here at DGM needs to be analyzed on the same day. And if there isn't an institution that is close enough or a logistical system that is in place, you will sort of delay the analysis, and then that calls into question your actual result. Furthermore, not all patients are suitable or will provide a reliable result in terms of sweat chloride, and those are the ones that have edema or hyperproteinemia or on mineralocorticoid treatment. So typically the patient profile tends to be those of greater than 2 weeks of age and 2 kilograms and asymptomatic where possible. However, because we pick these patients up so late, that is often not the case or not really achievable. Now, in terms of patient preparation, we require the patients to be well hydrated, where possible, not an acute illness, no mineralocorticoid treatment, no creams or lotions that might distort or influence our sweat chloride collection. And then it's important also to advise the patients that there are some adverse reactions are known. They are mild generally, with itching and urticaria being noted. So on the right-hand side here of the slide, you will see the South African Cystic Fibrosis Association's algorithm, the diagnostic algorithm for how these patients are supposed to be worked out. And on this slideshow, you will see, on that algorithm, you'll see sweat chloride concentration, sweat chloride conductivity, and genetic testing all are highlighted. However, in terms of sweat chloride concentration, there's currently only one institution that we are aware of within the Gauteng circuit that is performing it, and that is at Charlotte. They run a day ward, and there's no backlog currently, so bookings can be made and patients can be admitted for this testing. There's no testing done at Dr. George Macquarie Academic Hospital because we do not have the instrumentation. Steve Biko had a working instrument, but up until recently, they've not been able to run any sweat chlorides because they have problems with the actual instrumentation. Now, in terms of mutation analysis, it's generally done at the discretion of the clinicians. The kit that is currently available is in place in Braamfontein, and it's a 50 mutation kit, and it is able to detect that 3120 mutation that was commonly found in our black population. And the reported turnaround time is 2 to 3 weeks for results. Now, in the case that is highlighted, the turnaround time was around 4 months, and that should not be the case. And this speaks to the need for coordination between departments, whether it's clinicians in the laboratory, in order to expedite these testing. So what I would recommend is that if specialized testing is conducted with our institution, it's important, especially if it affects chemical pathology, it's important to contact the chemical pathology department so that we can arrange the logistics for these specimens. It's a well-established practice in our institution where we send urine organic acid, plasma amino acids to Groote Schuur, to the Red Cross Children's Hospital in Cape Town. So that is a well-established pathway. And in these sort of cystic fibrosis cases, it would be important for us to establish that kind of pathway with Braamfontein and with Charlotte Macquarie. Thank you.
Good afternoon, esteemed colleagues and guests. My name is Namaseko Zulu, and I'll be presenting on cystic fibrosis and nutrition. So according to the ESPN and EFSCAN guidelines, which are the European nutritional guidelines when it comes to cystic fibrosis, we recommend early screening of newborns and early nutrition intervention for diagnosed patients. Also regular anthropometry assessment, so we need to get the weight and the height and keep track of the weight and the height of the patient and the growth of that patient. We do regular blood tests for nutritional and disease-related markers. So we need to know your sodium, your chloride level, your albumin level in order to know nutritional status of this patient. We work very closely with the parents of this patient for nutrition education. And then we have age-specific energy intake to support and maintain normal weight of this patient. We advise on dietary intake of electrolytes and oral nutrition support as needed, as well as the supplementation of fat-soluble vitamins, as Dr. Motene mentioned before, that the patients have malabsorption of certain nutrients in the gastrointestinal tract. We also recommend a high-energy, high-fat diet, as well as a nutrient-dense diet. So when we look at the anthropometric guidelines of nutrition, we have 3 categories. So either the patient has a normal nutrition status, so in that case, we want to prevent we do preventative nutrition counseling. The second case is when a patient has special nutritional support for impaired nutritional status. So that's when we modify the diet and we add any oral nutrition supplements in order for the patient to gain weight. The last one is when a person has persistent undernutrition. So that's when we recommend to the doctors for a gastrostomy tube or an nasogastric tube, depending on what is wrong with the gastrointestinal tract and what's preventing the patient from eating already. So in that case, we have different categories for children under 2 years, for children 2 to 18 years, and children over 18 years. This is the one time where you'll hear a dietitian wanting a patient to gain weight instead of losing weight. In terms of methods of feeding, we always prefer oral feeding. So wherever possible, we will feed orally for this patient. Should there be any obstructions, like Dr. Matene said with their patient, they had to insert an NG tube, then the dietitian comes in and does the recommended calculations for that patient and recommends a specific feed for that patient. The patient deteriorated, end up having to have a gastrostomy tube, which is when the pediatric surgeons do an incision in the stomach and the food goes directly to the stomach. Should there be any obstructions within the gastrointestinal tract, then we will feed intravenously via TPN or PPN, as you can note in the diagram. So in terms of macronutrient requirements, the European guidelines recommend 120 to 150% of energy needs. The American guidelines recommend 110 to 200% of the daily required intake. In South Africa, we recommend 130 to 150% of the daily recommended intake. So with protein, we go with 20% of your total energies. Carbohydrates is 40 to 45% of your total energies. Fat is up to 40%, which is quite high, because on a normal healthy individual, we normally recommend 25 to 30% of total energies in terms of your fat. With the fluid requirements, they're also a bit high because of the patients sweating a lot. They lose a lot of fluids. Infant is up to 200 mils per kg per day. Over 1 year old, it's 1,000 to 1,700 milliliters per day. With adolescents and adults, it's 35 to 45 milliliters per kg per day. So with cystic fibrosis, there are complications. Sometimes we have cystic fibrosis-related liver disease, and then one of the most common is cystic fibrosis-related diabetes. So in terms of this diabetes, not the same, in terms of the nutritional needs, it's not the same as type 1 and type 2 diabetes. There are a few changes. The total energy, as with the diabetic patients, would go for we'd calculate as needed for growth, maintenance, and reductions, whereas with CFRD, we'd go for 120 to 150% of the daily recommended intake for age, specific to weight gain and growth of the patient. The carbohydrates remain the same for both normal diabetes and CFRD, not that diabetes is ever normal. With fat in normal diabetes, we want to restrict the fat as much as possible because we don't want a progression into other chronic disease of lifestyle. Whereas in CFRD, we have a high fat necessary to maintain weight of 35 to 40% of total energy intake. Protein is 15 to 20% in type 1 and type 2 diabetes, where CFRD we have 150 to 200% of the DRI for age. Vitamins and minerals will only supplement in type 1 and type 2 as needed, whereas the CFRD, it's a routine supplementation because they lose a lot of vitamins and minerals due to malabsorption in the GIT. With impaired glucose tolerance, in diabetes, we recommend a weight loss of 5 to 10% of total body weight recommended and a low-fat diet. Whereas with CFRD, we do not recommend weight loss. We spread carbohydrates throughout the day and consume nutrient-dense beverages. So I'm not going to go through this, it's very dietetic related, but these are some of the feeds that we have at Dr. George Moikari Hospital in terms of optimizing the nutritional status of our patients. We have enteral feeds, we also have TPN feeds as well. In terms of nutrient deficiencies, pancreas is compromised during when the patient has CF. So over 90% of patients with CF have pancreatic insufficiency. So that affects the absorption of your protein, of your fat, or several micronutrients, as well as insulin, which is very important in terms of moving the glucose from the blood into the different cells for use. We also have chronic pulmonary infection. So with that, there's an increased work of breathing. So then the patient's energy needs are higher. So we have to calculate a high caloric intake in order for the patient to not lose weight. There are other GI disorders associated with CF. There's altered GI motility, there's intestinal dysbiosis, there's small bowel bacterial overgrowth, there's GERD, which is gastroesophageal reflux disease, there's DIOS, and there's constipation. There's also CF-related liver disease, which I mentioned earlier, as well as CF-related diabetes. For patients with CF that have an iron deficiency, it is first suggested that we first resolve any inflammation because iron and inflammation do not go well together because of infections, and then we will only supplement with iron only if the deficiency persists. In terms of the nutrient deficiency, so we have the fat-soluble vitamins, the vitamin A, D, E, and K. We have sodium due to the excessive sweating of the patients lose a lot of sodium. Zinc, calcium, and magnesium are also prone for deficiencies in patients with CF. Patients with CF may have a very loss of appetite, so then we will suggest appetite stimulants in order to maintain the weight of the patient. In terms of probiotic use, there's still a lot of studies that are being done in terms of probiotics and the benefits of it in patients with CF. But so far, with a certain probiotic called Lactobacillus GG, there was a treatment done on women of childbirth age for 1 to 6 months, where it was found that when they were given this probiotic, it lowered the markers of inflammation, it decreased pulmonary exacerbation rates, and it lowered the frequency of hospital admissions. So in conclusion, medical nutrition therapy is very important to optimize outcomes in patients with CF. A diet must be high in calories, high in protein, high in fat and salt. We have to monitor the anthropometry of the patient, so we monitor the weight of the patient and ensure that there's minimal weight loss. And nutrition requirements are always patient-specific, so we need to see the patient and calculate nutrition requirements for each patient. Thank you.
Thank you. That was the patient experience we wanted to share with you. Chair, Program Director, 5 minutes for questions? Okay. 5 minutes for questions, and I will protect my panelist. There's a question there. The mic? Where's another one?
Hi, my name is Sarah Walters. I'm a genetic counselor and also the cystic fibrosis medical advisory committee. So one of my questions to the pediatrician actually is, was genetic counseling done for this family? How many children are present because there's a risk for parents in this family?
That's all.
Thank you for your question. So genetic counseling was done. We have Dr. Hani in our institution. So she spoke to both parents. Actually, the testing was also done for the parents. So as I mentioned in the talk, the grandparents, maternal grandparents are of Caucasian origin, but both parents are black, and the child actually, the patient that I'm discussing is actually a black child. I forgot to mention that. Is a black African child. Yeah, because most people think that CF affects mainly Caucasians. So it is, I think it's missed in most of black children. Yes.
We see a lot, it's not 40% of all our patients. So by only having the 50 mutation kits available in the NHS system, it's actually a challenge because we only look at 50 with over 2,000 mutations that are available, and I understand that there are resource constraints. Ideally, every child who is suspected of having cystic fibrosis based on IRT screening, which hopefully is about to come in, and has got clinical features of cystic fibrosis, then will be able to have full sequencing for CF. So that is my hope, coming from a genetics point of view, because I feel that our patients deserve it, and I agree we're missing a lot.
The other important thing is, I think one of the things is that when we request the test, we have to include that the clause that they must check for 3120 for black mutation. And in terms of George Mukari, I think I have diagnosed between 5 and 8 children, and some of them actually comes with protein energy malnutrition. And we think that the mom is not feeding the child, but if you check the background history, you find that this is a well-resourced family. Clearly there's something other than the intake, food intake problem.
Yeah, I agree, because kwashiorkor also is one of the, the thoughts immediately when the children are so small still and they're malnourished, but it's not, like you said, it's not because of resources. Thank you. Thank you.
Thanks, Aleta. Is there another question or comment from the floor? That's it.
Thank you to the panel for a very interesting topic. I just wanted to find out about the bleeding tendency in this patient, because you mentioned fat malabsorption with vitamin K malabsorption. Do you find that the patients are bleeding more or something like that? Thank you.
Thank you for the question. Yes, the liver gets affected, and we know that the liver is responsible for clotting factors. For the cases that I have seen, I haven't actually came across those with bleeding tendencies. Thank you.
If there are no other questions, Dr. Matebula, why?
You are looking at me, Chair, and I'm intimidated. Yeah, my question is, if I was awake, you said it's not common among black people. What was the statement? Is it the other way around?
The perception is that it's not common among black people, but it is.
Okay, so the question I have then is, do we have any effort to try and get, one, the health workers themselves, but two, communities to begin to appreciate its presence? Because I'm sure we do have a lot of kids that are being missed.
I'm actually not aware of any initiatives, but if anyone else is.
Thank you for that question. Earlier on, I was actually saying to Prof. Mawela that I think we are neglecting the primary healthcare sectors, because most of these children present in the local clinics. They present to the general practitioners with cough and signs of pneumonia, and they present there for their routine vaccination. And this is where some of these patients can be picked up. So if we raise awareness, educate primary healthcare our district hospitals. I think that will help a lot. Thank you.
Would it be useful to then suspect a child with recurrent cough?
Yes, the child who presents with recurrent cough or recurrent chest infection and does not respond to the standard therapy, then we have to think of cystic fibrosis.
I think the biggest issue is the myth. When you and I were in medical school, we were told it's a white man's disease. And that's what we need to deal with. It does happen in black children as well. Final question, final comment. Right, this brings us to the end of this session. Would like to thank all the panelists for their
We have one.
well
I think we
presented.
have one this side.
Thank you.
Okay.
Thank you very much. Prof. Mawala made it very clear when she started. She's very protective of her panel. And indeed, she did that. She says they are children. But thank you very much for such an informative discussion that we have had. One of the things that underpin initiatives that we've been talking about since morning, and what we are still going to be talking about tonight, is R&D. I think it underlines or underpins everything that we do. If we don't do this, what will be the basis for all these decisions, all these initiatives that we are talking about? So the next panel discussion will be focusing on that particular aspect, research and development, led by Dr. Telekan. If you can come to the stage with the panel, and then we take it from there.
Good afternoon, everybody, and welcome to the last in-person session. I'm Dr. Wesley Telekan. I'm the head of nephrology here at SMU and Dr. George Macquarie Academic Hospital. As was said earlier, we're going to be discussing R&D in rare diseases, and I'm just going to share a quick anecdote of my experience with this kind of problem. So a couple of years ago, when I was still a nephrology fellow, I came across a young 14-year-old boy who had X-linked hypophosphatemic rickets. And the only treatment that we could give him was massive doses of vitamin D and fleet enema orally, up to 20 mils 5 times a day. Now, you can imagine that is unpleasant. We did a bit of research, chatted to the family, and we found that there is something called Crysvita, which is a FGF23 inhibitor, available in the UK and the States, but it costs 100,000 Rand a month. So the medical aids won't get it, the state won't get it. So we wrote to Crysvita and we asked for compassionate use. And they said, we note this and we'll get back to you. And I thought that was the last of it. But they got back to me 6 months later and said, yes, we're going to do this. And just because of a little bit of, a small amount of effort and a bit of empathy, we managed to help this one kid. Now he's growing really nicely. He's not having to drink tons and tons of fleet enema, which is disgusting. And he's doing quite nicely. And we managed to do a public-private partnership where we got somebody from a private hospital, I probably can't mention them, to store the drug because of cold chain issues, and he's a state patient, and it worked really nicely. So there's room, and we need to work as a team. We mustn't fight with each other. But anyway, sorry. My point is that R&D is important to get new drugs. It's expensive, but if we don't start using them, we don't start doing things here on African soil, we are always going to be behind, especially when it comes to cost. But moving on, I'd like to start with the first talk. It's going to be an overview of the current therapeutic landscape, and it's going to be by Dr. Whittaker from the School of Pharmacy. Thank you very much.
Yeah. Just a bit tall. I think so. Thank you. Good afternoon, colleagues and everyone in attendance today. So we'll be talking briefly about the future of rare disease diagnostics and therapeutics and matters related to accessibility and affordability of treatment options. Those are the members of the panel today, and I would like to extend my thanks for them taking the time to be here with us today. So generally, what is known about rare diseases is that there's more than 7,000 different types of rare diseases. And unfortunately, the percentage of people being afflicted by rare diseases is going to only keep increasing. Like many of our colleagues have just mentioned, the numbers are also increasing in the population groups that we previously thought were exempt to these diseases. And the main challenge is that the patient journey is very long and it's tedious. In today's earlier talks, we were informed about how patients would only receive a diagnosis in the better part of a year. And that this brings a lot of agony, particularly to parents who have children afflicted by rare diseases. The main challenge that we currently face with rare diseases is the lack of awareness, particularly in healthcare professionals. It was highlighted by colleagues previously that there are a lot of myths and assumptions related to this. The symptoms are not always clear-cut, and in some instances we find rare diseases that can be mistaken for more commonly affected diseases affecting the population. There's quite a dearth of information regarding rare diseases, particularly about their therapeutics. Genotypic and phenotypic variations are many in this particular regard, and like has been stated, there's very little access to diagnostic and in many cases therapeutic tools. So these remain the biggest challenges associated with rare diseases. So the best way to go about it from a theoretical perspective is to follow a holistic approach. And the holistic approach would involve multiple aspects, not limited to computational science, phenotype-driven assays, complementary genes, the uses of RNA sequencing, and in some cases DNA sequencing as well. So that shows that the only way for us to deal with rare diseases is to use a multidisciplinary approach. So what are the recent advances in the treatment? In some cases, the use of hematopoietic stem cell transplantation can work. Antibody therapy has been used in some diseases, and as well as enzyme replacement therapy, which was particularly highlighted for the use in cystic fibrosis. The most exciting potentially treatment modality would be the use of gene therapy, which would allow us to replace a faulty gene with a gene that is functional. This would be done in one of two ways, by using DNA-based therapeutics or by the use of RNA-based therapeutics. There are currently a few marketed genetic drugs that are being used for rare diseases, with the earliest one being actually marketed from 2013, which is relatively new and shows the need for more research in this field. We can also use small nucleic acid drugs, but again, you will see that they have been only recently they have been developed. There's also a very small percentage of drugs that are currently available when you compare them to the drugs that are available for what we would consider conventional diseases. And that means that the need for research in these areas is much, much larger compared to that of conventional diseases. Using cystic fibrosis as a case example, like has been highlighted previously by speakers, it is very evident to see that the distress that the disease causes is very massive, particularly in young children, and the biggest symptom being affecting the lungs. Colleague previously highlighted on the gene, and we were using this as a template for the CRISPR technology that could possibly be able to be used to edit out the faulty gene that is responsible for the sweat chloride. And so we have a schematic here on what we could use as CRISPR technology, which is capable of editing out faulty DNA and replacing it with healthy DNA. The best way of delivering this presently has been suggested to be the use of nanotechnology aspects, which are not new, using liposomes, polymeric nanoparticles, as well as using adenovirus motivated drug delivery systems. There is a lot of nanoparticle-based gene therapy that is currently available and that can be made use of and platformed off of. And in this slide, we just show these. The gene therapy market has got massive potential going forward. It is estimated that the current value is about $9 billion, with that value looking to be increased to $44.5 billion in the next 10 years. Thank you very much. I'll hand over to the next speaker.
Good afternoon, distinguished guests and colleagues. It is my great pleasure to give a talk about precision personalized medicine, especially in application of rare diseases. What is a precision personalized medicine? It's a new shift in understanding of treatment of diseases, which considers variability of genes, environment, and lifestyle for each person. So it's a very targeted therapy. It is a paradigm shift from traditional treatment, which up to now is one size fits all. We don't want to use it anymore. We would like to be more precision-based. So we would like to target the right patient with right medicine at the right time, at the right dose. So the objective of precision medicine is a personalized, proactive, predictive, and precise treatment, which uses the innovation of genomics, transcriptomics, epigenomics, proteomics, metabolomics, and pharmacogenomics, which we call together as omic, as personomics approach to the treatment. So it's a combination of approaches to have a personalized precision treatment. And obviously with rare diseases where 80% are based, our genetic pathology is a genetic one, we concentrate on a genetic treatment diagnosis, but we should take into consideration also the environment factors, behavioral factors, psychological factors, lifestyle factors, which are all important. And all this should be integrated into big data. And now in the future where we are going into artificial intelligence, obviously that can be analyzed and utilized better. So obviously as pharmacologists, we concentrate more on pharmacogenomics or pharmacogenetics, but as I previously said, we should look into the personomic approach because there might be deficiency, or there might be mutation not only in gene but other part of our metabolic system. And as you know, there is a part of genome which encodes our CYP metabolizing enzymes. And it is very well known that there is a wide variety of these metabolizing enzymes, from poor metabolizers to intermediate one, to extensive and ultra-extensive. For example, very simple example with a codeine, which is used as an analgesic or in our cough syrup, we can have a poor metabolizer where simply the person will not react to the codeine as a pain, as an analgesic drug. But with, for example, extensive metabolizers, we can have a side effects. The same, for example, applies to HIV medication like efavirenz, and it is well known in African population, there is a 50% population where they've got a poor metabolizing property of efavirenz and therefore a possibility of side effects. But obviously genome sequencing is at the core of diagnosis of rare diseases, but all biochemical data as well. So it is a person-centered approach to the treatment, but it is a holistic approach which uses different markers, which I've already alluded to, but also external factors like exposomes, which can be internal environment, like for example, microbiome, gut-brain interaction, which was already mentioned a bit by our dietitians, and external one, like environment, food quality, diet, chemicals used in our agricultural. All these can actually affect our response to the treatment. So from diagnosis to the treatment, as we already heard, is a very often long way, which can take up to a few years. We call it diagnosis odyssey. So we have to understand first the genome, which is not that easy. There are specialized laboratories, not often many of them, as we heard. Then we need to find another target for treatment. And then we need to go into clinical trials, which usually also takes a few years. We should use also a new imaging techniques, like to understand the molecular and cellular level of interaction of the drugs. And by that we could accelerate, obviously, diagnosis. But it is a long process, and it is called Odyssey, from, as you know, from a mythological poem by Homer, where the king of Ithaca, it took him 10 years to come back from a war. So that's why we sort of use that approach as well, that understanding. So obviously, there are other problems. The treatment is very expensive, as it was alluded already. Not many drugs are therefore developed because companies doesn't want to invest in that. We call them orphan drugs. They don't have interest to develop because obviously the costs are high and not many people will use them. So it needs to, our understanding of and the perception of rare disease should shift. The perception should provide more incentive to pharmaceutical companies as well. And there are not many drugs authorized, not many one as orphan. Only in 2020 there were 160 authorized orphan medicine in Europe with 6 gene therapies. So it's very limited amount of drugs which can be used and very expensive, and not available obviously in often in South Africa as well, especially in public sector. So the challenges, as I mentioned, is genome sequencing. Only a fraction of patients are diagnosed. Not precise eligibility criteria developed. There is not even a starting point where we don't have a unified definition of rare diseases. For example, in the United States, rare diseases is defined as 1 in 200,000, while in Europe is 1 in 50,000. So it differs. So we don't have even unified definition. We don't know exactly how many rare diseases we do actually are diagnosed in the world. Pharmacologically, we only know about 3,000 genes out of 20,000 human genes, so also very little influence, not often understanding the mechanism of action. Very often difficult to link mechanism of action with the drug action. So that odyssey, the long way from the diagnosis to treatment should be shortened in order to help the patient. And definitely artificial intelligence development and networking will help in that respect. So what are the benefits of precision medicine initiative? First of all, it will give a new approaches for protecting research participants. We can design a new tools for building, analyzing, and sharing the medical tests. We should improve regulatory oversight. We should have partnership with scientists, wide range of specialists, advocacy community, university, pharmaceutical companies. That's what we are trying to establish now. The long term, obviously, as it was mentioned before, there's little understanding of a treatment, and we should actually advocate for teaching of our students and doctors to be able to recognize these diseases. And better treatment, better prediction, better understanding in order to prevent and diagnose and treat. So it should be an integration of electronic health record, which does not exist as yet. So implementing the precision medicine in clinical practice should take all these factors into consideration. We should have a genomic working group. We should have streamlined genomic testing. We should build on clinical database, which is non-existent now in South Africa. We should have national clinical workflows for diagnosis and care for rare diseases. Ethical and regulatory social issue and genetic testing should be addressed. We should promote research, we should promote innovation, we should work cross-border with virtual and develop a virtual network. Education is of paramount importance, as I already mentioned. So where are we standing in South Africa? In South Africa, there is a Medical Research Council, obviously, and Department of Science and Innovation, who are cooperating with the European Union, but we don't really have a national register and information center about all rare diseases. So we are hoping that SMU will be that excellence center and will eventually lead to the development of a register and information center, and will be a beginning of starting point for rare diseases to be recognized in South Africa. So we need to build infrastructure. We need to also attract the communities. We need to invest in the skills development. And integrate all the data, which actually in South Africa, as our rainbow nation, we are understudied and underdeveloped. We need to develop more. We need to do more testing. We need to develop, to have a database of information which we can then later utilize for treatment. So going forward, important is to have a multidisciplinary teams which will include clinical specialists, geneticists, policymakers, educators, but we heard about biotechnologies and so on, or nurses. We should all include them. We should all include them in the genetic education and genomic education. Also, the community should be included, dialogue for patient advocacy group, interaction research program. The network of genomic laboratories has to be established. There is now very shattered laboratories, but there is no coordination in that genetic testing. And we hope that we can establish SMU Center of Excellence for Rare Diseases, where we can coordinate all these programs and move forward. The only way to move forward is to get started, is to quit talking and begin doing. And for that, I would like to thank you, and the references are available upon request. Thank you so much.
Good afternoon, everybody. I'd like to thank the organizers for inviting me, and especially to my old friend, Dr. Tulliken, for inviting me. I've known Dr. Tulliken since he was wet behind the ears and started his research in genetics. I'm just going to give you a brief overview of next generation sequencing, and just put that in the history of how DNA sequencing came along in the first place. I think that you probably can't see this slide, but I've just highlighted like the important parts of DNA sequencing where that ranges from when DNA was first described. Sorry, I move around all the time. When DNA was first described, then to Sanger sequencing in the 1970s, which is still our gold standard of sequencing. So in fact, next generation sequencing is just the next part or the next step just in terms of technologies. And up to 1999, when human chromosome number 22 was the first fully described sequence of a human chromosome. And then I'm sure you'll remember the embarkment of the Human Genome Project in the early 2000s. They said that they published it in 2001, but actually there was still lots of genome that was missing and hadn't been sequenced yet. And then next generation sequencing came around in the 2000s, where since Sanger sequencing in the 1970s, so remember, I'm a medical scientist who goes way back when, who used to talk about chromosome walking and chromosome jumping, and I think that it's probably not even taught anymore, because that is what used to have to happen after Sanger sequencing. So if we have a look at next generation sequencing, it's our second step in terms of our technologies. There's a third generation sequencing, which I'm not going to cover today, because quite frankly, it's very complicated. But in general, there are two platforms where next generation sequencing can be done. And just to give you a brief overview of next generation sequencing, we extract the DNA or the RNA. We do a library preparation, we do templating, we do sequencing, and we do data analysis and interpretation. So out of those 5 steps of next generation sequencing, the easy part is the DNA extraction, the library prep, the templating, and the sequencing. That is the easy part. That's 3 days. The most difficult part is the data analysis, because you're generating gigabytes of data, And then the interpretation. So what does that data mean in the context of the clinical picture of the patient? So this is a picture of one of our Genexus machines, equipment. Green is good. Just remember, green is good. If it's red, you don't want to walk into that lab. And so what happens is that in our Genexus equipment, all of the steps of next generation sequencing are done in this one piece of equipment. Previously, we used to have, or we still do, we have chefs and we have sequencers that we can run independently. But basically what we do is that the sequencer can then detect millions of short reads of DNA, up to about 400 base pairs each. It then all gets aligned. We can test both, and then compared with a reference sequence. We test both RNA and DNA. We test both germline, so in other words, what you were born with, and we can test somatic cells. So we can test tumor cells. We can also detect cell-free circulating DNA as well from this methodology, which is just so awesome. And the types of variants that are detected can include your single nucleotide variants, your frameshift variants, your small deletions, duplications, your indels, and copy number variation. So once you've taught your software to identify certain copy numbers the copy numbers present, and obviously 2 is ideal for every gene. Once you've taught your software to be able to do that, then you don't need always to use other techniques like MLPA in terms of copy number detection. So just to take you back to, and I'm going to taking you back to our basic DNA code. Remember that there are 4 bases and 23 amino acids, and everything relies on this table. And everything, any individual change, anything that is different from what it is supposed to be as compared with the reference sequence, we need to investigate. So worldwide, international guidelines are used for interpretation, and the guidelines then lead us into classification. So there are certain factors, and there's a whole lot of hoops that we have to jump through in order to come to the classification either of pathogenic, likely pathogenic, which are the new words for mutation. So actually in genetics language, we don't use the word mutation anymore because we find that it gets misconstrued. So anything that is likely to cause the disease will be pathogenic. On the other side of the coin, the likely benign and the benign variants are ones that really don't make a difference, and they've been proven to not cause disease. There's sufficient evidence, including functional work. And then the problem is, especially in our diverse populations, is that we have lots and lots of variants of unknown significance. So what does that mean? Variant of unknown significance means that there's not enough data worldwide for us to say whether this change in the DNA contributes towards disease or does not contribute towards disease. And those variants of uncertain significance are going to stay as variants of uncertain significance until there is sufficient evidence to say otherwise. And so yes, reclassification does get done, which is fabulous, but it is a long and tedious process. And you can imagine the size of the databases that need to be scoured in terms of reclassification. So when we have a look at reporting any next generation sequencing data, common benign variants are definitely not reported on. There's no point in reporting a difference that's actually not going to make a difference clinically to the patient. All it's going to do is make them worry, and it's also going to make the doctor wonder what they've missed. So we use lots and lots of different bioinformatic tools. You have to get really good on the computer into databases and knowing how to use them, knowing what works for you. We just, at the moment, investigating a new database, a new software that we're planning to implement. But there's lots and lots of places that you have to look for evidence as how to classify any change or variant. And this is just one example of one of the reports that we have where a patient was investigated for 429 genes related to primary immune deficiencies. And so what came back was a gene that the variant was a common variant, and all that it really does is give an increased risk to getting Crohn's disease. And then the other three variants we have is variants of uncertain significance. So I think in one genetics report, the most number of variants of uncertain significance that I've ever seen in one patient has been 15. And they have to stay as VUSs until we've got more information. So what do we do when we have a genetics report? And now this is from a lab point of view, but also from a genetic counselor point of view, is that we have to first of all look for what inheritance pattern is used for that particular condition that the gene is associated with. Because obviously if it's autosomal recessive and you've only got one VUS in the gene, it's not going to cause the disease anyway because you haven't got a second variant in that gene. However, if it's autosomal dominant, then that's where you have to be careful and do your research in terms of how this correlates with the clinical features of your patient. We have to then be careful and look at classical versus atypical types of clinical features, and also for diseases that have later age of onset. So it's all very well to say, I'm thinking in terms of pediatrics, but then also the later onset diseases that you don't necessarily pick up as a child. You don't pick it up, it's there, it's present because it's in your genes, but it's not detected as a child. And so those are the later age onset. We also have to look at the population groups, and the problem is also we get so many VUSs because we don't have a lot of information about our Black African patients in terms of whole genome sequencing and how we compare. So everything that is compared with a reference sequence currently is based on a reference sequence of American and European population groups. And then you also have to look at other laboratory test results in terms of hematology or immunology or whatever the patient is, whichever disease the patient is presenting with for the genetic testing. So I just wanted to say that there are genetic clinics in our state sector, and of course I come from there in terms of my training and worked for the NHLS for a very long time. There are also very few clinical geneticists in South Africa, so there's only three training centres now for clinical geneticists, and they are often doctors who have specialised already in paediatrics or in oncology or in some other specialisation, but clinical genetics is now a primary specialisation. So when I was in state sector, it was still a subspecialty of paediatrics. There's also an insufficient number of genetic counsellors. So looking at the Department of Health guidelines, which were published in 2001, it was recommended that we have over 300 genetic counsellors to cover our population in the country. And that was in 2001, so that's 20 years ago population data. So at the moment, we've got less than 50 genetic counsellors in the country. The majority are working in the state, which is fabulous, but they're also working in the tertiary hospitals or the tertiary clinics. So they will be centred in Joburg, Cape Town, and there's no one in state in Durban, there's no one in state in Bloemfontein, there's no one in state in East London, for example. So the access to genetic counselling by clinical geneticists and by genetic counsellors is really limited. So that is really the message that I wanted to get across today. I know that I've sped through NGS. Please don't ask me any difficult questions at the end, but I'll leave it there for now. Thank you.
Thank you very much to our speakers. It's been quite valuable and enlightening for me. I've got lots of questions that I'm going to come and ask you separately, but that's my personal research interests. Can I open the floor to the panelists quickly, and if there are any comments or questions that the panel would like to raise? And on the floor?
I am putting the challenge perhaps to all of us to say, I think earlier today someone said we cannot be waiting for someone. We need to start doing something from our corners. And I would suppose the purpose as well of this Center of Excellence is to really embrace everyone within this university and in our communities and our private, I see the Empath and Lancet already they have steps within us. But my concern is how much of maybe some of those, of the rest of the community within this institution, are we planning to involve, are we planning to involve, and also what's the plan, so that as much as it's being, is it an initiative, or as I said, it's still being launched, so that we see the physio, the OT, the radiographer, the nutritionist, at whatever level of care, including the nurses as a whole. I'm just curious because I believe that if we speak education as someone, education, then it means it should start with us here than postgrads. So I was just, maybe it's me being confused, but forgive my confusion, but I'm really passionate that we should start at the education level and within our communities. So the primary health becomes still my thing to advocate for. Thanks.
So thanks. That's quite there's a lot of information in that question. There are quite a few questions within that question. What I'm going to start, and then I'll open up to the panelists. You know, primary care is important. Primary care and primary prevention is where what we need for our broad population. But that's not the only part of healthcare that is there, and we can have a huge impact with this type of stuff. I agree. I don't think it should only be postgrad, and it is so widespread nowadays around the world that I think we can start bringing it down from postgrad level into undergraduate level, but we have to start somewhere. And if we don't start somewhere, we're not going to start. The other point that I want to make is that we always need to protect our patients. This type of technology is very useful because it gives you so much information, but it is so easy to be abused as well. So we have to put in safeguards for our patients. We have to use the data responsibly, and we can really do some amazing stuff. But I agree with you. I want to start somewhere, and quite frankly, I don't really care where it starts, but it has to start. And then we go and bring it to everybody. But yeah, can I open it to the panel?
I agree with you in terms of we've got to take it out to the communities, and it's got to start at primary health care. As being a genetic counsellor, I used to work with an organisation that eventually became Rare Diseases. And we worked closely with the Department of Health at the time. And what we did was that we did training courses for nurses in primary healthcare settings. So I personally have trained over 300 nurses, but that was like over a decade ago already. The Department of Health at national level did take that on as a program, and it fell under the maternal and child subdirectorate, I think, at the time. So they did take it on as a project of theirs as well, which we helped with and collaborated with. The problem is just at the primary healthcare level is that, yes, lots of nurses have been trained, and then they retire, or they get moved departments, or they're not exposed in the primary healthcare setting to help us identify and push up the chain in terms of referring to tertiary, or to secondary or tertiary. So I think that absolutely training at this level, as far as the university is concerned, is essential, that you know what kind of technology is available even though we don't all have equitable access at this point in time. But what I do feel that we need is awareness in the communities. I feel that nurses are essential in terms of being aware of how, even if it's just a suspicion of a genetic diagnosis, to refer appropriately so that the child gets care as soon as possible. So that is my 2 cents worth.
Many thanks. It also gives me an opportunity to speak, even though I didn't present. If, if I'm hearing your point correctly, it talks squarely to access. You're pointing out that even though we are in this forum discussing these matters, they seem to be pitched at an academic level and really not talking to us in the audience as we are. And I think we need the wisdom from people like yourselves, people from the community, to take us from our ivory towers as people that are in academia, to bring us down to where we should be playing. Because remember, we're discussing a complex situation here that involves policy work that needs to be undertaken to change the mindsets and all that. And such awareness events are exactly what we need. And it's very important to have voices like yours in the audience, from the community, from elsewhere, to say, hey, you're not talking to us. Please do talk to us. Thanks.
Thank you, very well said. Are there any other questions? There's a hand over there.
Thank you very much, SMU. I would like to also thank you for saying that you are taking over the rare disease, because sometimes as facilitators, we facilitate and the nurses are given the certificate that is belonging to another province while they are in Gauteng. So I'm just saying that I don't want to divulge which certificate are we giving our nurses that we train in Gauteng, which belongs to the university somewhere where it acknowledge what we are teaching them, like hemophilia and everything. So I really thank you for taking over this rare disease and making sure that at least when we have training somewhere, we have the certificates that can belong to SMU or in Gauteng University than in another province that acknowledge our trainings that we're giving. Thank you.
Thanks. Yeah, I just want to point out that rare diseases is a team. It's a huge effort. No one person can do it, and there's a lot of amazing people in that team who are very, very dedicated. But thank you for your kind words. Okay. Are there any other questions? Thanks. Okay, then I'm going to close the session and hand back over to our chairperson. Thank you very much.
Thank you very much, colleagues. According to the program that I have, we are almost at the end of today's or this morning and afternoon session. But there are a couple of things that I just want to share as a reflection on what we had gone through this morning. Thereafter, I will ask someone who's going to do a closing remark, and we call it a day for now. For someone who is not in the medical space, this day was quite refreshing, where colleagues were talking about medical issues without using what we call medical speak. Using what we call layman's language or laywomen's language, to be politically correct. In a way that complex issues are broken down into smaller chunks, that all of us, most of us at least, can go home and say, I have an understanding of what is really going on. And I think for me, this is one of those big things that I take from this day. The one thing that I also found is that as I was listening to colleagues, especially the different panels that we had, I thought to myself, are these SMU employees? Why is it that we don't know about all these great things that we're doing as an institution? And what I could come to is a conclusion that says, we don't brag as much as I think we should. We don't beat our chests as much as I think we should. We are modest, humble. Maybe we need to throw that out of the window and start to make noise. And lastly, I want to say this. I think the most senior people here in our midst is Professor Demana and Professor Mawela. I suppose this is as a challenge and a word to take back to the executive to say, next time when we have these events, one, we must close the university activity so that everybody comes here. Two, it must be compulsory for all managers to attend these functions. And I'm saying this because we sit on the 5th floor and take decisions about some of these things. And if we are to take those decisions with this understanding, it will help us to make much more informed decisions, which talk to the academic project. And I think really if we can take this message back to say, we all must be here. Whether you are a technical person, whether in support department, it is something that I think we must just make it a ruling. I am in the communication space. My job is to brag about SMU. But I was sitting here and just saying to myself, how didn't I know about it? I would have bragged even more. And I think this is the kind of things that we need as a university. And lastly, I want to say to Professor Harry, Prof. Baker, who have been our champion from SMU side, thank you very much for educating us. And I'm hoping that this is not the first and last of these conversations, because we need more of these conversations going forward. With that said, I'm going to ask, apparently there's no closing remarks, is it? I'm doing the closing remark. So basically I'm going to say, I hope this is not the last, the first and the last. I'm hoping that we are going to have more conversations around these and many other related issues, because we can do with more of these conversations. To move from theory to practice, to look at how what we do impacts the local community in Karanku and surrounding areas, how what we do impacts our teaching practices, how what we do impacts on the national development goal of the country, the continent, and I dare say the world, isn't it? So with that said, thank you very much for the time that you have given us. And thank you very much for the open conversations that we have had. And then I hope that we're going to have another session which is exciting in the evening, which I'm told will be online.